Good morning, everyone. Good afternoon. Thank you for joining us on day 4 of the Simplified Approaches learning event. I'm going to give it another couple of seconds before we get started to allow more participants to join. Thanks. Okay, let's get started, everyone. Thank you for joining us today. My name is 𝘁𝗶𝗺𝗲𝗃, and I'm a nutrition specialist with UNICEF. We're very excited to launch day 4 of Simplified Approaches learning event. Today, we're going to be really diving into the combined nutrition protocol to learn more about the simplifications under this approach. We will spend all of today focus on this, and then we'll do a quick wrap up at the end. Thanks to all of you who have been joining us over the course of the week. We hope it has been interesting and useful. I will now turn it over to Bethany Marone, who will be facilitating the session today. Over to you, Bethany.
Thanks, Grace. Again, good morning, good afternoon, and good evening, everyone. So my name is Bethany. I will be co-facilitating the session today. I'm a nutrition advisor at the International Rescue Committee and a co-chair of the Simplified Approaches Working Group. I will be assisted by 𝗵𝗇𝗃𝗀𝗃. She's a CMAM advisor with the Global Nutrition Cluster Technical Alliance and with the International Medical Corps. So we're really looking forward to engaging with you. Please remember to put your questions in the Q&A box so that we can address them. Today you'll hear from Dr. 𝗹𝗶𝗸𝗲𝗃 Dembele, who is the Health and Nutrition Coordinator for the International Rescue Committee in Mali. You'll also hear a presentation from 𝗵𝗇𝗃𝗀𝗃, who is the co-facilitator. And you'll have the opportunity to ask questions from Dr. Rosette Siandi, who is an emergency nutrition officer with UNICEF in DRC, and also Dr. 𝗶𝗵𝗄𝗃, who is the nutrition cluster coordinator in DRC. And then finally, you'll hear from our friend from the week, 𝗹𝗶 Woodhead, who will present on an exciting new RUTF calculator tool. For the next 90 minutes, we're going to give you a brief presentation and introduction to the combined protocol, what, why, and where it's being implemented. We'll provide you a summary of the evidence. We'll ask a few questions from you about your knowledge, perceptions, and experience with combined protocol. And we'll hear 2 country case studies. First, from DRC, you'll hear how the Ministry of Health assessed feasibility of implementing a protocol in 2020. And second, from Mali, you'll hear about the processes, experience, and lessons learned from implementing the combined protocol across an entire district since 2018. We'll have a Q&A, and then we'll finish our session by walking you through this new RUTF calculator tool. So what is the combined protocol? First, I want to emphasize that what stakeholders commonly refer to as combined protocol, which is, even the name of this session, actually reflects modifications that both combine and simplify existing treatment for uncomplicated wasting. These include simplifying admissions and discharge criteria by using MUAC and/or edema only, expanding admission criteria so that all children under 5 with a MUAC less than 125 are eligible for treatment, using a single product to treat both SAM and MAM, and reducing the dosage of that single product. So most commonly to 2 sachets of RUTF per day for severe wasting and 1 sachet of RUTF per day for moderate wasting. So why a combined protocol? A combined protocol is intended to improve coverage by ensuring that treatment is available for all wasted children, not just SAM children, which we know is the reality in some contexts. Continuity of care by streamlining programs in a way that ensures wasted children don't have breaks in treatment due to operational issues like lack of supply or potentially tricky referral procedures between OTP and TSFP services, for example. It is intended to improve quality by delivering treatment at dosages that, according to the evidence, align with growth expectations and energy calorie needs. And lastly, it can achieve cost effectiveness when services for SAM and MAM are unified and streamlined, resources are shared, and we can use these cost savings to expand coverage and improve treatment availability. Like the other simplified approaches you've heard about this week, combined protocol is not yet part of WHO normative guidance. However, there is a very large body of evidence, perhaps the largest of the simplified approaches, I'm not sure, ranging from clinical trials to operational studies that support simplification and combination of existing protocols. So we want to spend a little time showing you some of the evidence. First, on this slide, I want to tell you about a clinical trial called COMPASS that tested a simplified combined protocol, so all 4 of the modifications I mentioned, as the intervention arm against the gold standard CMAM treatment, which is RUTF for SAM and RUSF for MAM. The study, which was cluster randomized non-inferiority trial, was conducted in Kenya and South Sudan in 2017 and 2018. And it was the first rigorous academic clinical trial that showed a simplified combined protocol is as effective as the standard treatment protocol. Or in technical terms, it is not inferior to achieving recovery. We also found no evidence of a difference in secondary outcomes that we care about, defaulting, non-response, length of stay, for example. We saw similar mortality in both the intervention and control arm, and also similar time to recovery. Finally, we found that the protocol was in fact cost effective. It cost $123 less per child recovered. So as a result of this definitive evidence, today the protocol is being piloted in several countries and contexts, 2 of which you'll hear about today, and was endorsed by the UN last year as a COVID adaptation. Then just quickly, I want to mention that in addition to this trial, it's important to know and have confidence that the modifications, the individual modifications, are backed by a lot of research too. So I'll just highlight a point or 2, but we'll share the slides with references. So first, regarding to MUAC and edema-only programming, more than any anthropometric criteria, MUAC identifies children who are at greatest risk of death, and MUAC can be used as a proxy for growth, which is how we are using MUAC in this protocol. Next, expanding admission criteria to treat both SAM and MAM is, not just good for logistics, but there is evidence in addition to the COMPASS study to suggest that combined treatment can meet SPHERE standards, it can improve recovery and increase program coverage. We saw that in Sierra Leone and Burkina Faso. And then lastly, there's not a lot of debate about RUTF for SAM, but in case you're wondering, RUTF, well, we know that there is no WHO protocol for treatment of NAM, but we do have research and studies that show that lipid-based products with dairy protein, so like RUTF, are very effective for MAM treatment and may even increase recovery over the use of RUSF. And then lastly, regarding the reduced dosage, it's important to know that as children recover from wasting, their rate of MUAC and weight gain actually slows, meaning they require less, not more calories as they recover. So whereas current dosage tables for RUTF give children extra RUTF as they gain weight, the data and evidence shows that children with a MUAC less than 125, their caloric need can be actually met by 1,000 calories per day, or about 2 sachets of RUTF. So finally, now that you have that background, it's worth noting that the combined protocol is the second most popular simplified approach, with about 30 countries engaged in combined protocol research, pilots, or emergency use of some kind. So now we're going to kind of poll you all and ask you some questions about your experience with combined protocol. And Martha is going to help me do that.
Thanks, Bethany. So now we're going to go to Mentimeter, like Bethany has said, and the link is going to be posted in the chat. If you don't, and that's a direct link to Mentimeter. If you're not able to use that, then you can just go to mentimeter.com. And use the code, which is also going to be put in the chat. And the code is 159184555. Please share freely, and let's see how this goes.
Let's see, can you all see it?
No.
Okay.
Yes, so the first question is about the countries where we were from, and there's quite a lot of geographical variance from different global regions. We have a couple of people from Guatemala. We have a lot of people that are working on global level, so they specifically represent a lot of countries. We have Kenya, Canada, Colombia, regional offices of Dakar, Yemen, Peru, Nepal, the US, Switzerland, Uganda, Somalia, and Sudan, Indonesia, Cambodia. So basically we have a wide array of people attending this session, and we're happy to have you on board and hoping we're learning as much as we can. Canada, the DRC, the Philippines, Myanmar. And the next question is asking what type of stakeholder are you working with the government, implementing partners at field level, non-field level, which could be regional, global support. And so far the biggest number is the UN, followed by implementing partners, that's field. And certainly implementing partners are much more than the UN. And then we have also implementing partners at the non-field level being the third group of participants. 6% so far from the government. About 9% from the donors. So the biggest percentage really today in attendance are the implementing partners at the field level or at various country level, followed by the UN, and then implementing partners that are probably working at global or regional level, followed by the donor community and the other group that's not specific, and then the government and the academia. Thank you. So this is more of a yay or nay question. So if you've implemented any of the methods or approaches that have been mentioned, please go ahead and give us a yes. We have 4 for yes, 8 for yes, 5, 6. A very huge percentage or number that have really implemented this. And we are at 26 for yes, 29, then 18 for no. And we are 30 for yes, 20 for no. Thank you. And now you can go on and tell us if you've implemented or supported directly any of these modifications by just moving the button from one side to the other. Quite a number have done work-only programming, as you can see. Expanded admission and single product almost fall within the same level. Reduced dosage being the lowest so far. Okay, thanks. So I guess work-only programming takes the lead. And now you're looking at some of your practical concerns, and then I would like you to prioritize which one you think is your most challenging or issue that you have, and then which one will be the second and the third. The lack of guidance both at national and global level seems to be one of the major concerns. As we all can see, lack of national guidance both at national level keep on changing, but indicating that these two are a major concern for a lot of participants today. And lack of evidence being the third. And that was in terms of policy. Now we can look at in terms of implementation. Supply chain takes the lead so far. Funding coming on slowly. Okay, as we can see, the major concern or the main concern is the supply chain aspect, followed by funding, and lastly, at field level, operational level, really to do with increased case loads that would somehow affect how the work is being done. And additional concerns, just as we did previously, would concerns concerning human resource be quite a high priority or a medium or a low priority? Same as training. I think human resources and training and logistics so far taking the lead. Logistics, supplies, and this is again in line with what was previously polled against, which was supplies being a major concern, followed by training and human resources, monitoring and evaluation and human resources are now in the same position. And then reporting and community acceptance are also last in the same position, and they consider to be a medium operational concern. Okay, we have been attending this event for the last 3 days. Today is the fourth and final day. We've listened from people's experiences, and we're going to learn so much more just to find out what are you individually optimistic about with regards to the combined protocol within your areas of work. Someone says it is simple. The other talks about it's easy to understand, it's currently gaining acceptance, and hopefully it's going to be implemented, reduces costs, it's cost effective, there's easy dissemination, there's ongoing acceptance, it is streamlined, it's evidence-based, it's pragmatic, there's better coverage, and quite a lot, but I think a lot is coming out in terms of simplicity. It meets the needs of the child. It's a combined protocol. It brings new options in this area, which is a good thing. Yeah, so pretty much clearly saying there's so much that we can learn and so much we appreciate from the combined protocol. It's effective, it's simple, it focuses on the child, it increases coverage, there's continued treatment, it is feasible to apply in various areas. And we've had these about 45 responses, and we hope to get so much more. Thank you very much, and we hope that by the end of the day, we'll have learned so much more. I will continue to speak right now, and we're going to go on to present the technical support that was provided on the simplified approach to the DRC nutrition cluster. That's the government and the partners. As Bethany said, my name is Martha Nakakande. I'm hosted by International Medical Corps, working with the Alliance, and also a member of the Simplified Approaches working group. Next. So we did provide support to DRC last year, and partly this year with regards to implementation of the simplified approaches in the country. They were recommended as part of adaptations during the COVID-19 pandemic. As a recommendation in the National Guidance on Nutrition Programming, there were, however, challenges which were, there was no defined package of approaches or adaptations to implement at that time. There wasn't very much in country technical capacity with regards to the simplified approaches. And so they sought technical support from the GNC. By then we were still referred to as the 𝗶𝗶𝗺𝗲, and currently it's the technical support team. So we did a feasibility study or a consultation and then agreed on a package which included the combined nutrition protocol and the use of the family mark. And they also went ahead to also use the community volunteers or the community health workers, a platform that they have to do the treatment. It was proposed to pilot the simplified approaches in 5 health zones. However, they did start with 2 zones. Next. Overall, the outcomes of the support were we facilitated a consultation on the various approaches or adaptations, and this is what we'll look through in detail to really see what should you look at, what should you focus at before you take that decision to say, well, we're going to implement a combined protocol, we're going to implement the family mark, or we're going to implement something else. We also reviewed the existing program data versus the impact of the approaches. And to be specific here, we were really looking at one of the ongoing concerns that we all know, which is the weight for height 𝗁𝗁 versus the mark-only assessment and admission. We developed training materials on the selected approaches, including the combined protocol. We carried out training for MOH staff and the nutrition partners, and in total there were about 28 participants, and also worked together with the cluster to develop and update their monitoring and data collection tools. Just to let you know that it is in plan to share experiences and lessons learned. There will be a general webinar that will be shared internationally for everyone to engage with the DRC team and learn so much more from them. Next. So what are some of the key considerations would you look at when you're implementing the combined protocol? What did we look at for DRC's case before they really reached that decision of choosing to implement? They, as I said, they chose to implement the family mark for reasons that came out of this feasibility study. And for the combined nutrition protocol, they chose to use the single product and also to do mark and edema only admission criteria. And then they also carried out activities or treatment of malnutrition in the community using what they call the 𝗁𝗶𝗺𝗲𝗃, which is a platform of community volunteers, 𝗹𝗶𝗸𝗲𝗃 or modern mothers, and some specific community leaders. So when we were doing this feasibility study, it was a matrix where we were just categorizing to give a grade for each of the different combined protocol and other aspects, you know, giving a green light or a yellow light, which is we're not very sure, and a red light, which is this is definitely not possible or cannot be done. And we looked at the experiences. So just to go back a bit behind, we were not trying to find out what is the combined nutrition protocol. We already knew what it is. We were only trying to find out what do we need to have in place, or what can we be sure of before we go ahead and implement any of the combined nutrition protocols. And so we looked at experience and program strategy. Here we're looking at, you know, either individual experience or organizational experience with regards to any of the simplified approaches, and also, you know, the contribution of this towards overall nutrition programming for the organization and for the Ministry of Health. Is it really relevant? Is it necessary? Was there justification to do it? Remembering this was during COVID-19 pandemic, really at the start, that this can also be applied in any of the contexts, you know, before you go ahead. Then we looked at the health system structure, you know, existence of health centers, existence of OTPs and TSFPs, and functional stabilization centers. Because even though you're carrying out combined nutrition protocol, there are children that will still need care in higher facilities, for example, stabilization centers. So are they there, or does a given community have access where this partner work, this nutrition cluster partner works? Do they have those aspects? And other existing programs, if you really have to work with the community. We also assessed the part on human resources. What's the existing technical capacity for there already existing community worker platforms? So you have volunteers already on ground. They may not necessarily be for nutrition. Do you have the ability to do the training? This, for example, was during COVID-19 where accessibility of physical movement was not possible. So if you want to implement this, would you be able to do the training if the training was necessary? That's supervision. You also have to look at incentives. If, for example, maybe there's a reduced number of staff, or maybe the number of staff, like you already mentioned, one of the challenges could be increased caseload. How is this related to the number of staff that are existing, and what are some of the challenges and what are some of the solutions? We also looked at supply chain and other operational aspects, and I know this is something that's very interesting to everyone. So supplies availability, supplies movement, security, lead time, contingency stock, how much stock would you need at national level, regional level, district level. And at this point, I'd like to say, some of the responses may be specific to DRC, and that's why it's important that different partners, together with the cluster or the sector, depending on which country you are, sit and have these discussions. Are you going to have the same amount of supplies that you probably planned when you're using the routine or the usual existing protocol, or is something going to change? And all that needs to be factored in before you go ahead and start implementing this. We also looked at community engagement, willingness, acceptance, safety of mothers, issues to do with stigmatization. We know that in some communities, there's already this aspect of children who are taking the red plumpy nuts are probably more malnourished or not cared for. So then what's going to happen if you have this large number of children who are taking the plumpy sap, suddenly also taking the plumpy nut? Is it a case of now, all these mothers are not looking after their children? The involvement of the leaders, community awareness in general on what you want to do and how you do it, and how they will, receive what you're talking about. We also assess the feasibility of M&E tools. What we did with DRC is really to just update the existing tools and make sure we captured relevant indicators, and maybe Rosette or Khalil will probably share some of the experiences. Integration and coordination, what coordination is in place, ways of working, and working with the different parties treating some and those treating mom, as you can see. So there's quite a lot that you can look at when you're trying to implement the combined nutrition protocol. Next slide. What worked well? This support that we provided as the Technical Alliance was really remotely done because at that point in time there was no movement. The best thing that really happened was the motivation and involvement of all the cluster partners, attendance daily. They were willing and ready to get this going, even though everyone was in different places within the country. Good collaboration between the cluster coordinator and the advisor, which was me in this case, and all the cluster partners. And also the most important aspect for me was the fact that the national nutrition protocol, or the national nutrition guidance during the COVID-19 pandemic had given this a go-ahead. It has clearly mentioned you can use the simplified approaches during the context of COVID-19. So there was a basis for all the discussions that was going on, although at that point you couldn't say there was global protocols and everything, but there was an acceptable guidance that had been signed by the Minister of Health. And so that helped people to go ahead and get this done. We were able to reach so many concerned partners via internet, even though at that point there was no movement. A lot of people in different parts of the country, other people were even outside of the country. So internet is a good thing, and that for me was a lesson plan. Yes, next. Some challenges. Some partners did not agree with some of the adaptations or some of the aspects that we were looking at in terms of this combined nutrition protocol, especially the MAC and ODIMA admission criteria only. The consultation process did not include the community due to accessibility issues, which would have been very important. So most of the conclusions regarding community were just assumptions based on the partners' on-ground experience. Definitely there were fears from partners in terms of availability of supplies, and that was addressed. I think Khalid will maybe share with us some of the experiences with regards to that. I also noticed that it's important for us to factor in this. Availability of funds can help hasten the pilot process. I remember clearly UNICEF saying, but there's funding for us to do this pilot activity. And so partners were really excited, like, oh yeah, okay, there's money for this. We're going to go ahead and get it done. Not all aspects of the combined nutrition protocol are feasible for all contexts. And even for countries as large as DRC, they may not be feasible for even the different regions in the country. So you really have to look at it as a case basis. And even when you want to look at country level implementation, go on to the ground and see, does this really work in the West? Does this work in the North or in the South, or whatever regional presentations or administrative areas you have? Remote support has a wide reach if there's good internet, proper facilitation of the process, and active engagement. That for us was something that we really find very, very important. A lot of times you have to, think of a lot of expenses that we're going to do in terms of training, but there's also much you can do online if you have access to good internet and be able to start, going without really having to wait for a longer time to cascade your trainings and your support. And briefly, that's it from me. I'll say thank you right now, and I will send you over to our wonderful Dr. Salim Dembele to present or share with us the experiences from Mali. Dr. Salim is going to be speaking in French, and therefore this is just a reminder for everyone that you can still use the interpretation button if you want to listen to his discussion in English. Thank you very much, and over to you, Salim. Salim, c'est toi maintenant. Vous êtes à mute.
Okay, merci.
You're muted. Well, thank you very much. Thank you very much. My name is Dr. Salimou Dembele. I am the Health and Nutrition Coordinator in Mali. I believe I will now share information on the sanitary center in Mali on simplified approaches. Next slide, please. I would like to start by sharing Mali's context and Mali's nutritional context. As you may see on the map, this is a recent map from November. In red, you should be able to see 3 regions from 10. Most of them are within phase 4 for food security. In other words, the global nutritional reality is quite concerning within Mali. Survey outcomes from 2021, which provides updated data, up-to-date information on the country's reality, and you should be able to see that the PTC is below 10%. In the 𝗁𝗶𝗺𝗲𝗀 region, we're below 10.9%. According to the country's reality, the 𝗁𝗃 values are somewhere around 2.9%, and for our region, 𝘁𝗶𝗺𝗲𝗃, it's somewhere around 2.6%. In Mali, for acute malnutrition, usually the treatments are provided within health centers. When you assess this information globally, you will see that 30% of the population has to travel around 15 kilometers since that's the distance from their location to the health center, basically. So now, treatment for ASC's cases since 2017, and the idea was to provide attention to SAM cases at a community level. We still have not been able to obtain specific data or information from communities. We only have information on the community level implementation, but we don't have the national implementation yet, since the implementation is still not active in order for us to facilitate coverage, access to attend malnutrition. At a national level, UNICEF has been able to implement and support participants in order for them to assist the current situation. Next slide, please. We are still taking into we're still within the project's context at a district level. We're currently implementing, and it is an ample district, as you can see in the map. The district is border with a desert. In other words, part of the district is dedicated to agriculture, and the other part of the district is an entire desert. Now, the community is composed by a nomadic population, and also agriculturers. We currently have 35 health centers and 38 secondary education sites at a rural level, which is where we are trying to implement the combined approach protocol. The study started back in December 2018, and right now we have assisted 27,148 children admitted. 95.8% of the children have been treated. Average time is somewhere around 6 weeks. The Ministry of Health assists us with the implementation. In other words, there are implementation partners, and they currently help us with the MARA sanitary actions. This was possible thanks to the ECHO program and thanks to private foundations. Now let's talk about the implementation, the planning process, amongst others. For the planning stage, we have included several stages, and it has taken us more than 8 months, so we may coordinate and in this way be able to adapt accordingly along with UNICEF and along with the ministry in order for us to support our actions, support 𝗺𝗺, and advance with the research. UNICEF supported us at first, and then we continued with the ministry. There are different committees involved in the study's validation, And the process started back in March 2018 and it ended just November this year. And the study started recently in December. This planning stage to the agreement has also generated the implementation of a training process. In other words, what I mean, it's about sanitary teams that need to be trained since they need to focus on specific projects and they need to focus in communities to implement protocols. Implementation has been approved and supervised by teams. First, for about 3 months, we assessed this information and then we spaced and extended visits to the health centers. We have conducted district visits and regional visits every quarter. We've also went through a monitoring session within the sanitary district. The idea was basically to assess the impact generated, and in order for this to be possible, we have included some coverage studies and some approaches and additional researches. We also included a study on the approach's cost efficiency. As I previously stated, we have trained health agents. The objective was basically to train on the combined protocol. In other words, the diagnostics methodology, criteria identified as well, since it follows a specific parameter. At the same time, there are different studies addressed from severe cases and moderate cases, and there are different reporting tools applied for the protocol's implementation. So in other words, we conducted a 3-day training for health centers. The training session was conducted through different modules delivered by the 𝗺𝗃 staff members. Duration, 3 days. 3 days of theory and 2 days of practical training, along with the 𝗺𝗃 support. Standing by. ASC's training sessions at a community level. Basically, the idea was to train them on diagnosis and admission criteria, treatment, and follow-up parameters. According to identified groups and reporting tools. Why at a community level? Well, basically to facilitate access and admission, and in this way improve coverage. A great part, or a large part of the population is located, a great part of the population is quite far away from health centers, so coverage and follow-up in set locations has been a bit complicated. We have trained through the 𝗺𝗃 team, and I must say, this is a theoretical and practical training session, and it takes about 2 months, and we have about 3 days of theory.
Pouvoir faciliter le suivi et qu'il y ait moins d'erreurs et
We have seen There are actions to facilitate follow-up in such a way that we avoid admission mistakes or mistakes in general on how we address objectives. We also conducted a theoretical assessment and a practical assessment for about 2 months in order for us to truly be able to follow up training sessions. And every day we had different validation objectives, improvement objectives, in order for us to truly make sure they were appropriately focused. In the end, those responsible for the health center would conduct another assessment before authorizing follow-up at a community level. This stage has been very important for the implementation of said community approach, and at the same time it has been greatly appreciated by the ministry. They have appreciated our actions, our approaches, amongst other interventions, since there was a great amount of consultation at a community level. After the training session, we continued with follow-up, assessing our progress, assessing the implementation as well, the protocol, and basically we wanted to monitor and verify
problèmes et les
the
insuffisances.
locations from which they were collecting the data was known to them. In other words, they wanted to identify the issues or related insufficiencies. The follow-up was conducted by the IRC team and by agents from the Ministry of Health. This was conducted
National du Mali
semestrally every 6 months, and it was also conducted by Mali's nutrition direction or directorate, and they truthfully helped us in order for us to assess and understand the information which basically drove us to the study. The data was collected individually through the OMAR platform. The data used was collected
avec les
tablets. The data was also discussed with agents before validating, so we may improve. This would allow us to improve quality of attention to be provided. We also addressed integration at a ministerial level, and the data shared within health centers as well. The idea was to obtain ample vision, ample information on collected data.
Nous avons quelques leçons apprises lors de cette implémentation qui a commencé en 2018. Et
Lessons learned.
par rapport au caseload
First off,
qui était initialement calculé sur base de rapport bataille, mais on s'est
the
rendu compte
highest
que
caseload.
était au-delà vraiment de ce caseload.
First off, it was based on the existing PTC, but we noticed it was elevated by the end. We haven't noticed any affections or interruptions, and at the same time, we had to assess days of acceptance or admission within health centers, and basically the idea was to assist children the same day that they came into the center. So we have seen an increase in attention days or service days. At the same time, we have noticed an important transition phase that truthfully from health agents, it has been a little bit difficult for us to understand the transition phase. And the ministry is not necessarily in favor to this transition, of this transition. The phase basically has to do with a child coming into the PTC. The MOAC measures were 115 millimeters before moving on to the moderate stage, which was a bit confusing. Other aspects we've learned are basically related to supervision, the consumption of ATPE, and how the calculations were facilitated for agents. We didn't have to check the table constantly, so we would see the data from children, nor admission criteria. Honestly, agents have demonstrated it is a simplified process, and this has allowed them to generate shorter reports with valuable information. Standing by. Very well. So I would like to thank everyone for your attention. Muchas gracias, 𝗹𝗶𝗺𝗲𝗃. Muchas gracias por su presentación, muy interesante. Very interesting. We're now going to move on to the Q&A session. Thank you so much, 𝗹𝗶𝗺. I believe we have some questions in the chat box. And we will invite Dr. 𝗁𝗂𝗋 and Dr. Rosette to please join in the Q&A panel so we can start with the Q&A session. Standing by.
Try to streamline it and have and help the translators to be able to guide the discussion. We'll start with a couple of questions in the Q&A where some are read in French, but we'll ask them in English and then have the translators ask the questions. There's a question from George which says, if you have children who are severely malnourished that have acute malnutrition, and that is both using the weight for height Z-score and the MOAC criteria, where exactly within this protocol would such type of an infant fit? If their measurement, both weight for height and MOAC, indicate that this child is severely malnourished, would they qualify to be part of the combined protocol, or would they not qualify? I would like to respond to this question briefly, but then I'll also give Khalid the opportunity to discuss. I think with the combined protocol, it is important that countries agree on what they want to implement and how they want to go about it. So we've said with the combined protocol, we intentionally use MOAC and edema. So in this case, as long as they qualify for edema, and rather for MOAC, then they would be admitted within the program if the particular entity is carrying out the combined protocol. I do remember, however, that for the case of DRC, they agreed that such a case would be called, and Khalid will help me here, would be, I've forgotten the exact name, but such a case would be referred to the inpatient facility or the health facility for further assessment. But as long as they call their MOAC qualifies them and they don't have any complications, then they can be treated within the center that is implementing the combined nutrition protocol. I hope that answers your question very well, George. Khalil, do you have any addition?
Merci, Martha. Comme la question a été posée par George qui est en RDC, donc francophone, acceptez que je lui donne quelques éléments.
Thank you very much for your question.
Et donc,
en plus, there are some elements
alors, en plus de ce que Martha a dit,
aside,
Je dois juste préciser
And
que pour ce qui
aside from what
concerne
Martha stated,
le cas de la
I
RDC, on avait
would like to join her
décidé
comments, but I would like to
pour pouvoir
specify
tenir compte des
that
enfants
with
des enfants
IRC,
qui ont un MUAC
we decided
entre 25 et 30 mm et qui soient
that whenever
probablement
children
qui soient admis
have
avec le poids taille, qu'on
between
puisse leur donner
25
une
and 30
alternative
mm, and
avec
at the
le
same
plan
time they
PIDOS.
were admitted, we should be able to offer an
Même si
alternative
en
with the
pratique,
plan.
ceci n'a pas été le
Even
cas
though
à cause de questions
this was not
d'intrants,
necessarily the case in practice,
l'intrant qui a été
considering
utilisé, qui devait être utilisé pour
the
faire face à ces
question from
situations-là.
Anton.
Mais c'est une question
I
d'éthique que
believe this was
dans
applied
le
according to
pilotage
the
de ce genre,
specifications, but
qu'on
I think it's
puisse
mostly a question related to
donner une
ethics.
alternative à ces enfants qui allaient être admis avec
We
le
need to
poids
be
taille
able to provide an
dans le
alternative
programme,
to
même si
this
le
person,
critère
to these children
d'inclusion,
as
c'est le
well,
MUAC, c'est
so
le
they may
DEM.
be admitted into the program, even though the inclusion criteria is diverse,
MUAC, périmètre brachial et l'œdème.
especially if it has to do with MUAC and edema use. Very well. Thank you very much, Khalil.
Antonio Vargas, who says, I think it is important to separate the needs assessment. In the needs assessment, the actions developed with community health workers from what is needed for the combination of protocols. For you, what are the key needs to identify in the protocol part of the combination of MAM and MAS programs? If I get you clearly, I think you're trying to say it's important to separate if we're applying the combined nutrition protocol and also if we're applying the treatment while using community health workers, we should be separating those two assessments. And for the combined protocol, what are some of the key needs to identify? As shared in my discussion, we looked at the feasibility. It was looking at the nutrition combined protocol and other aspects. And I think it's important, just as like the Mentimeter has shown, that you look at, the aspect of supplies, the agreement, within the health system, within the health structure to really implement this combined protocol, the reporting and the monitoring, and also the impact these changes are going to have on your workforce. How are the changes going to be? Who is going to do what? And how can this be supervised and monitored to make sure that you're still providing services to the children and ensuring coverage as much as it should be? There is another question again from Antonio. In which situations or contexts would you recommend the use of the combined protocol where you use RUTF for the treatment of MAS and MAM? And I would like to give this question to Salim from Mali. Salim, vous êtes là?
Oui, je suis là.
Il y a les questions ici. Antonio Vegas.
There's a question from Antonio Vargas. In which situation or context or situations would you recommend the use of the combined protocols? Well, considering the context, I believe the combined protocol could be adapted to any context, especially ER context or emergency context. The emergency context follows an easy to apply and easy to develop protocol, considering it's an urgent topic, because when we speak about logistics, it's light for it to be implemented. It's easy to implement, and at the same time, I believe the emergency context, at least in my perspective, I believe this is the most likely context to apply in. I believe it could be done in the case there's any interruption of services or similar. I believe this should allow us to currently take action, which is what we do right now. It has truly allowed us to take action and close the gap accordingly, as we have stated previously. I believe this is very important since at the moment that you implement, it does affect admissions. And we spoke about them since, truthfully, they haven't had any community reference, and in regards to health centers, it's been difficult. For mothers, they were a bit discouraged because they would go home and several children did not have any guidance. And for this reason, we had to play an important role. I believe that if there is any specific context for acute malnutrition, or
Merci.
either moderated or
On va
severe
discuter. Il y a
cases.
aussi une autre question du point
I think there's another
qui a été
question for
demandée.
you.
C'est quel est la calendrier de visite
Someone
pour
asked,
temps masse et MAM selon le protocole combiné?
which is the,
La
I'm
fréquence
sorry,
de
can you repeat
visite.
the question? Oh, the frequency. Okay. How often should visits take place? Okay, well, according to the combined protocol, there should be a follow-up period. It should be a daily follow-up period. Actually, weekly, not daily, I'm sorry. Every week, children with either acute, with either moderate acute malnutrition or severe acute malnutrition, I think still that for moderate acute malnutrition cases, we should move on at least for every 2 weeks, because we do have a topic to take into consideration. We've had some specific complaints. Sometimes they needed to cover around 20, 30 kilometers, and truthfully, this was quite upsetting. So we needed to understand if we could provide a more extended treatment frequency.
Merci. J'ai une
Right now, it's
question
weekly.
pour Dr. Zut.
Thank you so much, Doctor, for
Madame,
your
si les tumeurs
response. I have another
identifiées au niveau
question.
communauté ou au niveau du centre de santé?
If the treatment was performed at a community level or within health centers?
Si
I
le
believe
réseau
Martha
n'a
is
pas, je
muted.
crois, un problème avec les réseaux, je vais demander Khalil.
I believe Rosette is not available right now. There seems to be a problem with the network, with the internet. So Khalil, can you please answer for us?
Yeah.
Le traitement a été effectué au niveau communauté ou au niveau du centre de santé?
Hmm. Merci,
So
Martha,
once again,
pour cette
has this
question.
been performed at a community level or
Effectivement,
within health centers?
laissez-moi
Well, thank
aller
you,
un peu
Martha, for the
derrière avec une
question.
phrase.
Effectively,
En RDC,
was the
le
treatment done
vrai
at the community
problème
level
que
or
nous avons,
facility?
c'est la question de
I believe the
l'accessibilité
real
des personnes
problem
qui vivent loin des
has
centres de
to do
santé
with
à la prise en
accessibility.
charge.
It has to do
Et
with
donc,
those
pour
that live
nous,
far away from health
l'adaptation qui
centers.
consiste à amener le
For
traitement au
us,
niveau communautaire était
adaptation
l'adaptation la plus adaptée.
has to do
Permettez-moi
with community
l'expression pour
level
le contexte de
actions.
la
I
RDC.
believe it was the most
Et
adapted one,
effectivement, le
if we
traitement
can call
a
it
été
this way.
fait au niveau communautaire en utilisant les
So
structures qu'on appelle les
treatment
CAC.
has
Les
taken
CAC
place
sont
at
les
a community
Community
level
Animation
through
Committees
the
qui sont
community
au niveau communautaire,
alimentation
et
committee,
les relais
CACs,
communautaires
which
relèvent de
take
ces
place at a
CAC.
community level,
Et
of
ce sont
course.
eux qui assuraient le traitement des cas au niveau
They are the
communautaire.
ones who share the
Donc,
treatment at a
effectivement, à
community level,
l'image du
basically.
Mali, c'était un traitement communautaire et c'est quelque
So
chose que nous
for
avons assez
Mali,
apprécié
it was a community level
les
treatment,
adaptations adoptées pour le
and
contexte de la RDC,
it
pour
is
résoudre le
something we
problème que nous
have
avons en termes
truly
de couverture
appreciated
géographique.
for our adaptation in context, and in this way solve the issue on coverage.
And thank you all the participants for bearing with us with the language changes.
Yeah.
I hope you're still able to listen in from the different interpreters. Unfortunately, due to time constraints, we'll not be able to answer all the questions physically. We already have some of the panelists responding to some of your questions directly. So please go into the Q&A and look at the questions that have been responded to by our panelists. And I'm sure we'll be sharing a lot more content within the final emails that we'll share with you concerning this event and be able to respond some of these questions. If we are not, the simplifiedapproaches.org website is open for everyone. I will now hand over to, Sophie, and Sophie is going to be presenting in English. So again, just a polite reminder, you can still use the translation button for you to select the most appropriate language. Sophie, over to you. Thank you.
Thank you very much, Martha, and hello to everybody. My name is 𝗁𝗶𝗺𝗲𝗃, and I'm working in the nutrition team of UNICEF headquarters. And I'll just very briefly run through a tool that we've developed with the Simplified Approaches Working Group to support the implementation or planning and implementation of the combined protocol. What this tool does is helps to calculate the caseload and supply needs. Slide, please. So it's an Excel-based tool. You can see a quick snapshot of it here with some very brief instructions on how to use this tool. And this tool is available on simplifiedapproaches.org. Slide, please. So why did we develop this tool? So we want this tool to help implementers understand the programmatic implications of increasing the MUAC cutoff, using MUAC and edema as the only admissions criteria, and using one treatment product. As we know, the combined protocol has a selection of different modifications included. So what this tool focuses on is those three: the expansion of the MUAC cutoff, the MUAC only, and one treatment product being IUTF. And this tool is really for implementers who are considering the combined protocol. It's to be used at the inception phase to understand the operational implications and to assess what resources, both financial and HR, would be needed. The tool was developed using the existing approach to calculate the number of children expected, which is based on population data, on prevalence data, and that data is combined with incidence and coverage. So this tool calculates burden, caseload, and supply needs of the standard services, so what's currently being implemented versus modified admissions. And just the last point, how accurate are these estimations? The estimating caseload and supply needs tends to be kind of imperfect. And that means that these forecasts should be carefully monitored and importantly revised according to any contextual changes. The estimations are only as good as the data that we put into them. Slide, please. So in terms of the data entry, we're looking at some key basic data on the implementation area, the population, and the prevalence of wasting, with both indicators, weight per height and MUAC. Slide, please. And then we have some variables which are applied to this data, including the proportion of children 6 to 59 months, the expected or target program coverage for severe wasting, moderate wasting, the incidence correction factor for severe wasting. What we're using here is the most recent published evidence calculating wasting instance from the 𝗁𝗁𝗃𝗃 publication referenced below. And also we apply variables regarding the number of sachets used per child under the standard dosage and under a modified dosage. Slide, please. And what this calculator does is essentially give you three results: the burden or the number of children who are suffering from severe weight or suffering from wasting as per the standard protocol, and the MUAC less than 125. The caseload, so then we're applying to the burden coverage or expected admissions. And then we also have supply needs in terms of number of cartons of RUTF. Again, looking at the standard protocol, how that's calculated now today, and also comparing that against the combined nutrition protocol. Slide, please. And this tool also gives some visualizations comparing the two, the standard and the combined, again, really to help in terms of estimating caseload and supply needs. As we know, as we've seen, those are two of the kind of key considerations from an operational context that need to be considered. That's all from me on this. I think, Bethany, if you go to the next slide, I'll hand back to you. And just to reiterate, that tool is available on simplifiedapproaches.org for any questions, or if anybody would like further information on that, please don't hesitate to be in touch.
Thank you, Sophie, so much. And thank you also to Martha and to Dr. 𝘁𝗶𝗺𝗲𝗶𝗆 and also to Dr. 𝘁𝗶𝗺𝗲𝗃. We really appreciate you taking the time to share all your knowledge and experience with us today. So I'm actually going to hand it over or back to Grace Fennell for some closing remarks. She's been fearlessly leading this event for the week, and yeah, I look forward to her comments.
Thank you, Bethany, and thank you everyone for attending today and over the course of the week, but also the presentations today, I think were really valuable. Before we move to sort of closing the event, I think this session was really, really key. I know that if we go back to the beginning of the event, we really wanted to focus on the black box of how do we implement these different modifications. And while it was a lot of information today, I think there are a lot of resources that will be shared after this event. It's important to note that this is not a one-size-fits-all approach. Even in the combined protocol that we just reviewed, in some cases, perhaps just two of the modifications will be adapted to a modified protocol. It's not necessarily that every time we do MUAC only admission, we will also do the simplified, the use of a single product. It really, really depends. And I think that's something that came out of this session, the context. It's important that all the context is really taken into consideration. And something that really came out in addition to that was the need for consultation at all levels, and starting from the community all the way up to the national government. If we are talking about policies being adapted even in under emergency settings. It's also important, I think this came out in the example from Mali, to really consider the transition of moving to a modified protocol. How do we carefully ensure that transition? Again, I think it goes back to the importance of communication, consultations, and also adapting to all the contexts, to the context in which we're looking to work. I understand that this is a lot. The caseload calculator that we just reviewed, as Sophie said, will be available online. So thank you for joining the session today. And before we move to a close, we would like to do one more Mentimeter. Bethany, I think if you can pop into the chat box again one more time, the link to that Mentimeter. And we're just asking you to think about this week. It's been 4 days of a lot of information being thrown your way. And I know that maybe not all of you were able to join every single day, but if you could, in the Mentimeter, think of what is one topic you learned this week that was presented over the course of the week, or one thing that that you were surprised to learn about in terms of the implementation of the simplified approaches. So it could be 1 or 2 words of what is something that you learned, or something that was surprising to you as you were hearing the presentations over the course of the week. Then everyone can just click in that link. That would be great. Okay, we're seeing some responses come in. Family MUAC is one that came out. The feasibility assessments, I think learning about that many countries are implementing, that we're seeing better outcomes using these simplified approaches. Planning, as mentioned, maybe learning about the importance of planning. The community aspect, the need for feasibility assessment, I think that goes to looking at the planning. Let's see. The need for monitoring in ICCM+, importance of family as social behavior change. I think that's an important link to Family MUAC, the SBC aspect of it. The experiences that are being shared, I think, is something that people hopefully learned from this week. Many of these are already being implemented, that they're not just 1 or 2 pilots. I would say that there's a lot of experiences and examples of which to share. Great. Well, thank you again all for joining. I think that there was a lot of rich topics and learnings and many, many details that I know sometimes can be hard to process. After the event, we will be sure to share both the presentations, but also we have been recording each day in English, French, and Spanish, so we'll have those available. Please be on the lookout for these coming your way to your inbox, but also this will all be uploaded to Simplified Approaches website. So in closing, I would like to hand it over to my colleague, 𝗹𝗶𝗸𝗲𝗏, the Senior Nutrition Advisor at UNICEF, who's going to do sort of the last closing before we finish the event. Thank you, everyone. Over to you, Saul.
Hi, can you hear me okay?
Yeah, loud and clear.
Great. So yeah, I don't want to take much more of your time, but I just wanted to say a couple of quick things as a way of closing. The first is thank you. Thanks not only to everybody who was behind the preparation of this event. It was incredibly well organized and I think incredibly practical in spite of all the practical limitations. So really appreciate that, but also really appreciate everybody making the time for it. I want to thank you as well, everybody who has taken part of the last few days, for actually having generated the experiences and the evidence that has been integral to this discussion. We couldn't do, or we couldn't advance this agenda if we didn't have many of you out there trying many of these things and documenting it and sharing it. So I personally, and I was saying this to Grace yesterday, I'm incredibly happy to see the Simplified Approaches conversation having moved in a very short period of time from something that was happening in a fairly organic and sort of uncoordinated way to something that we're now getting on top of collectively and really pushing collectively on the basis of that emerging evidence. So thanks to everybody who has made that leap possible. And I just want to close by encouraging everybody on this call to keep testing, keep trialing things, keep piloting things, keep generating evidence, keep seeing what works in your context, what doesn't work, because all of that evidence will power this particular revolution in the early detection and treatment of child wasting. So keep at it, keep sharing, and keep letting us know. And we look forward to continuing this journey with all of you over the next few months and years to come. So thanks everybody for being here, and all the best during this festive season. Thanks a lot.